Hello, everyone. So, welcome to the first session. We will be discussing the EMQs on cervical cerclage today. We will be also referring to the GTG and the NICE preterm guidelines here. Okay. So, let's start with the first question. A 28-year-old woman at 19 weeks of gestation presents for her routine antenatal visit. She has no prior history of preterm birth or pregnancy loss. Her scan performed today reveals a cervical length of 22 millimeters. What is the most appropriate management? You can put in your answers in the chat box and then we'll discuss the answer. Okay? Right. So in this question, the answer, let's see what the answer is. Consider prophylactic vaginal progesterone. Okay. So here in this question, as you can see, she is at 19 weeks with no history and there is a cervical length of 22 millimeters, which is less than the cutoff. So what does the NICE guideline say? Consider prophylactic vaginal progesterone for women who have either of these two. Either there is a history of preterm birth or spontaneous loss, or a transverse vaginal ultrasound showing a cervical length of 25 millimeters or less, right? So here the answer would be I. Consider prophylactic vaginal progesterone. Clear? We'll move on to the next question. A 30-year-old pregnant woman presents for her antenatal visit at 18 weeks of gestation. She has a history of spontaneous preterm birth at 32 weeks. Along with that, the TVS performed at 17 weeks shows cervical length of 20 millimeters. Which of the following is the most appropriate option? So here are the options from A to K. Okay, let's see what the answer is. Offer a choice of prophylactic vaginal progesterone or a prophylactic cervical cerclage, right? So look carefully here at the NICE guidelines, which says offer a choice of prophylactic vaginal progesterone or prophylactic cervical cerclage to women who have both. That is, a history is present as well as, see this and, okay, there is a history and results from a transverse vaginal ultrasound shows that the cervical length is 25 millimeters or less, right? So when you have both a history plus decreased cervical length, you offer either a progesterone or a cervical cerclage. Is it clear? We'll move on to the next question. A 35-year-old at 13 weeks of pregnancy has a history of two second trimester losses at 19 weeks and 21 weeks. What is the management in this case now? So we all know that for history indicated cerclage, there should be at least minimum 3 second trimester losses. So that would not be the answer in this case. What else do you think could be the option? Yes, okay. Let's see what the answer is. No cerclage and continue surveillance. Look at the highlighted box over here. It says history indicated cerclage should not routinely be offered to women with less than 3 previous preterm births and second trimester losses without additional risk factors. All right. So there are certain risk factors also which you must know, which we'll be seeing ahead. So here, as she has two second trimester losses, in this case, you can see history of two second trimester losses. Here, what we will be doing is at present, she does not need a cerclage, but we will continue monitoring her. So continue surveillance, right? Okay, so E is the option. Moving on to the next question here. Okay, before that, as I told you, these are the high risk and the intermediate risk factors, which we all must know. And what is the importance of this? See, if you have in any question, you have any of these risk factors, like high risk factors, which will include all these having a previous preterm birth or second trimester loss, previous preterm rupture of membranes less than 34 weeks, previous use of cerclage, non-uterine variant, any anomaly, intrauterine adhesions, or a history of trachelectomy. All these are high risk factors, and if a woman has any of these, she requires a secondary screening test every 2 to 4 weeks between 16 to 24 weeks. All right. And what are the intermediate risk factors? These include women, including those who have a history of previous full dilatation C-section. And second one is significant cervical excisional surgery. That could be either a lead surgery with an excision depth of, it should be more than 1 centimeters, right? Or it also could be more than one procedures or a cone biopsy. right? So these are the intermediate risk factors. And if a woman has any of the intermediate risk factors, then she has to undergo a single ultrasound scan, that is transvaginal cervical scan. And that should be between 18 to 22 weeks, right? So if she has a high risk factor, then you need a cervical screening, which is serially done every 2 to 4 weeks. And if there is any intermediate risk factor present, only a single transvaginal scan is done from 18 to 22 weeks onwards, right? We'll go to the next question now. A 28-year-old woman at 18 weeks of gestation with previous preterm birth at 30 weeks shows a TVS and cervical length of 27 millimeters. So here the length is less or more. It is more than the cutoff. It is not less than 25. So that would not be considered. There is only a history. Now, what do we do when just a history of preterm birth is present? Here are the options from A to J. Put your answers in the chat box. We'll see what the answer is. So here again, the answer would be no cerclage and continue surveillance. Now, why? Because she has only a single history. What does the Green Top guidelines say? Women with a history of spontaneous second trimester loss or preterm birth who have not undergone a history indicated cerclage may be offered serial sonographic surveillance as those who experience cervical shortening. That is, if the length goes less than 25 millimeters, they could be offered a ultrasound indicated cerclage, right? So here what will we do is, as she has a single history, we will be just monitoring her right now. So no cerclage and continue surveillance. Option E would be the answer here, right? Okay. Question 5 now. A 30-year-old woman at 22 weeks of gestation with previous 1 second trimester loss and cervical length on transvaginal ultrasound showing 24 millimeters. So now this woman has a history of one loss. Along with that, she has a decreased cervical length of less than 25 millimeters. So now when you have both the criteria fulfilled, what is the answer? Okay, let's see what the answer is. Ultrasound indicated cerclage, right? So this patient is having both, that is a history along with decreased cervical length. See what the highlighted box says. Women with a history of one or more spontaneous second trimester loss or preterm births who are undergoing ultrasound surveillance of cervical length should be offered a cerclage if the cervical length is 25 millimeters or less at gestation of less than 24 weeks, right? So this is the option, that is ultrasound indicated cerclage. But also, if you can see the NICE guidelines, which is the box below, offer a choice of prophylactic vaginal progesterone or cerclage. So if you, in this question, if you had an option that you could offer her either a cervical cerclage prophylactically or progesterone prophylactically, this entire option would be the answer. But here I cannot see any of these. So here we will have ultrasound indicated cerclage as the answer. That is option C. All right. So you have to club together both the Green Top guidelines as well as the NICE guidelines, and you have to look into the options and choose the most appropriate option among all of them, right? Okay. So question 6 now. A 30-year-old woman at 27 weeks of gestation presents with 3 centimeters dilatation. Her membranes are visible on post-speculum examination, but there is no evidence of any infection. She has no contractions as well. So here, what do you think is the answer right now? Is she a candidate for rescue cerclage here? So what are the criteria for rescue cerclage? First, let me know that. Okay, we'll see what the answer is here. So here, yes, as you know, it is an emergency or rescue cerclage. You should know what the criteria is, till what gestational age can rescue cerclage be done. So you see the highlighted part here, it can be considered up to 27 plus 6 weeks of gestation, right? And the second column, second box here, shows the advanced dilatation of the cervix, that is more than 4 centimeters, or membrane prolapse beyond the external os appears to be associated with a high chance of cerclage failure, right? So what do you understand from this is, up to 27 plus 6 weeks of gestation, a cervical cerclage, a rescue cerclage can be done, and till 4 centimeters. So if in the question the cervical dilatation is 4 centimeters more than that, or if the gestational age is more than 27 plus 6 weeks, you cannot offer a emergency or a rescue cerclage. Is it all right? Okay. Let's move on to the 7th question now. A woman at 28 plus 6 weeks of gestation presents with exposed membranes but no contractions. So this is a similar question, just the gestational age is increased now. And as you saw clearly, beyond 27 plus 6 weeks of gestation, a rescue cerclage is not to be done. So here, there cannot be any cerclage done, right? So we'll see the answer here. Do not insert a cerclage, that is H. Option H would be the answer, right? Okay. I hope I'm clear. We'll move on to the eighth question. A woman with cervical cerclage at 32 weeks develops regular contractions. Okay, so regular contractions should ring a bell in your mind that it is an established preterm labor, right? And in such a case, a cervical cerclage, if it is present, has to be removed, right? So let's see what the answer is. Answer is option F, remove immediately. So as I told you, regular contractions means active preterm labor or established labor, right? Established labor would be more appropriate here. And see the highlighted box. In women presenting in established preterm labor, the cerclage should be removed to minimize potential trauma to the cervix, right? So now, as she's having regular contractions, we will assume that she is in preterm labor and the cerclage will be removed. Moving on to the ninth question now. A 23-year-old female presents with preterm premature rupture of membranes at 30 weeks of gestation with no signs of infection. So what will you do in such a case? Now she has come with membrane rupture at 30 weeks and there is no sign of infection. So obviously PPROM is a contraindication for cervical cerclage. So the cerclage options would not be your answer. What can be the other options which you can think of? Let's see what the answer is. You can delay the removal for about 48 hours so that you can give steroids, or you can think of doing in utero transfer in case the facilities for the delivery and the care of the baby is not available. Let's see the highlighted part. In women with PPROM between 24 to 34 weeks and without showing any signs of infection or preterm labor, delayed removal of the cerclage for 48 hours can be considered in order to facilitate the in utero transfer. Also, steroids can be given in that time frame for the lung maturity, right? Moving on to the next question now. Women with cervical cerclage done at 18 weeks presents with PPROM at 22 weeks with no signs of infection. Now here, look carefully at the gestational age, that is 22 weeks, presenting with PPROM. So what do you think the options could be and the answer could be? Okay, write it in the chat box. Right. Let's see what the answer is. Remove cerclage immediately in this case now. Can you wait in such a case? Just see the highlighted part again. The red arrow shows, given the risk of neonatal and maternal sepsis and the minimal benefit of 48 hours of latency in pregnancy with PPROM, either before 23 and after 34 weeks of gestation, delayed suture removal is unlikely to be advantageous. So what do you understand? That if PPROM is there in a woman less than 23 weeks or after 34 weeks, the cerclage has to be removed immediately, cannot wait for 48 hours, because that the benefit is less and the harm to the baby is more, and likely sepsis is also more in such a case, right? Okay, we'll move on to the next question. Women with a cervical cerclage done at 18 weeks presents with PPROM at 22 weeks with no signs of infection, right? So we did this question just now. Okay. Moving on to the 11th question now. A woman with transabdominal cerclage, and now she's come at 37 weeks to you. What will you do? Where do you remove the cerclage right now? Let's see what the answer is. She requires a cesarean birth and the suture may remain in situ. Just look at the highlighted part here. All women with a transabdominal cerclage require birth by cesarean birth, right? And the abdominal suture may be left in place following the birth, or it can be removed as well. So here, primarily, when a woman presents with transabdominal cerclage at term, that is 36 to 37 weeks, then what will you do? You will just take her for a cesarean section. The suture may be left in place. All right. Moving on to the 12th question now. Routine vaginal progesterone after a history indicated cerclage. Is it recommended? Let's see what the answer is. Routine use of progesterone supplementation following cerclage is not recommended. So answer would be K, that is not recommended. You either offer a vaginal progesterone or a cerclage, never both, right? None of the guidelines say that you offer both to a woman, okay? Yes, so these are the nice guidelines in preterm labor. Just go through all these points. When do you offer? When do you consider? Very important. Both these points has to be remembered, right? And also the last point you can see here. When do you consider cerclage? When there is a transverse length, cervical length of 25 millimeters or less. Along with that, you either have a history of PPROM or you have a history of cervical trauma. Then you would consider cervical cerclage. All right. So again, you have to know about the cervical cerclage green top guidelines as well as the preterm labor and birth NICE guidelines for answering all these questions. So coming to the most important points of these now. So incidental finding of cervical length of less than equal to 25 millimeters. You can see any of these options. You have to choose them. Either no cerclage, consider prophylactic vaginal progesterone. If there is an option having the entire statement, you will choose that, right? If a woman is presenting with less than 3 losses, then no cerclage has to be done. Consider prophylactic vaginal progesterone. And cervical length monitoring has to be done serially. If the cervical length comes out to be 25 millimeters or less in any of the scans, then you will consider a ultrasound indicated cerclage. History of loss is there, and along with that, there is also a cervical length which is reduced, that is less than or equal to 25 mm. What will you do? You will here offer a prophylactic vaginal progesterone or prophylactic cervical cerclage. So when there is both history of loss with reduced length, you will offer. When there is either one, that is incidental cervical length is reduced, you find it on the cervical scan, or if there is less than 3 losses, you will consider, right? Okay. If there are 3 second trimester losses, we all know we will go for a history indicated cerclage. If there is just one loss and the cervical length is less than 25 mm or equal to, we will go for an ultrasound indicated cerclage. A rescue cerclage is not done after 27 plus 6 weeks. That is the cutoff limit. If a woman presents at less than 23 weeks or more than equal to 34 weeks and presents with preterm premature rupture of membranes, cerclage has to be removed immediately. As we know, there is increased risk of sepsis and the advantages and benefits are very less as compared to the disadvantages, right? Coming to the last point, in case of multiple pregnancy or twins, routine cerclage is not recommended just for a case of multiple pregnancy. All right. Okay, so that's it for the extended match questions for cervical cerclage. Please go to the green top guidelines and also go through the NICE guidelines as well. And if you have any doubts, you can always contact on the Telegram group as well. Thank you.